on CME, just how to get them. I have nothing to disclose related to this presentation. Today we're going to talk about cognitive behavioral therapy and relapse prevention. These are really large topics that I'm going to do a very quick and dirty overview of. So hopefully by the end of today, you'll have a basic idea of the primary components of what CBT is, whether you're doing it or you're referring people for it. And some of the specific skills that fall under the relapse prevention umbrella. So identifying triggers, how to manage urges and cravings, and behavioral contingencies. So the first thing that ties a lot of this together is sort of understanding the stages of change model. This is not part of CBT, but it helps us to know when and how to use CBT, specifically relapse prevention. So we're not going to start everybody on relapse prevention. It's really going to be most beneficial for people who are solidly in action moving into maintenance, which are sort of our last two domains in the stages of change. So that's where people are very motivated to do the work. They're already making the positive changes to decrease use significantly. And now they're moving into a phase where they just need to maintain those positive changes that they've made. So that's where relapse prevention skills have the most effect. Another way of thinking about it is sort of in alignment with another term that we use a lot, which also can fall under the CBT umbrella, which is harm reduction. So we sort of start people off with harm reduction that can apply to just about anybody, regardless of their stage of change, because we're wanting them to just be as healthy as they can be in this moment. So encouraging any positive change is going to fall under the harm reduction umbrella. Now, once we actually start doing some core behavioral techniques that are about helping people obtain a decreased use state and maintain a decreased use state, that's where we're using solid relapse prevention skills that can be carried into that maintenance phase. So what is CBT? It is called cognitive behavioral therapy. It is a talk therapy. And at its core, what it does really well is teaches people a set of skills to link their thoughts, feelings, and behaviors together. So they understand why they're acting in the way that they're acting. It has very, very good evidence for treating addiction in general. So multiple controlled studies have been shown to prove CBT effective for a host of different substance use disorders, as well as behavioral addictions. It's also very effective at working with people who are duly diagnosed. So they have a mental health condition as well as an addictive disorder. And you can use CBT to treat both very effectively. It's also highly flexible, so you can implement it in multiple settings. You can pull out standalone techniques, which I'm going to show you today. So obviously it's going to be better if somebody does a full CBT protocol, but if that's not your role with the patient, you just want to know how to apply a couple CBT techniques, you can use it for this purpose. You don't have to use a full protocol and still be using some basic CBT. It's meant to be short-term and highly focused, which means you work with the patient to identify what it is you're going to work on in utilizing these techniques, and people can get benefit within a very brief amount of time. It's also been shown to be highly effective in combination with medication therapies, like the opiate replacement that many of you are prescribed. So in a nutshell, what is CBT? Well, it works on what's called the cognitive behavioral triad, which means something happens in the environment. So that's this activating trigger or an incident that occurs. So for instance, if you're driving to work in the morning and somebody cuts you off in traffic, that's the environmental activating trigger. The very first thing that happens, even though we're typically not aware of it, the very first thing that happens is we have a thought or a cognition. And those thoughts can either be accurate or they can be a little distorted or inaccurate. And because we're typically not aware of that automatic thought, the very first thing we become aware of is the emotion. So somebody cuts us off in traffic, we don't necessarily pay attention to what we said, but we are aware of that initial fear and maybe the anger or the frustration about it. Now that emotion triggers a physiological response, which has a set of predictable behavioral physiological sensations associated with that emotion. So if I'm experiencing fear and anger, I would have an increase in my heart rate, maybe my respiration, I'd start to sweat, I'd start to feel hot. And then that's going to trigger a behavioral response. So stepping on the gas pedal, flipping the person off, cussing, any of those things would be behaviors that would naturally follow the emotion of anger. And if we back it up even further, we could say, we probably said something to ourselves like, that jerk, I can't believe he cut me off. Or how dare he, right? So the thought actually triggered the entire cascade. Now, the nice thing about understanding this and teaching this to patients is we can't necessarily intervene at the level of emotion or physiology. We're not going to change those two things. But what we can do is we can change the beginning and the end of this cycle. So we can intervene at the level of the behavioral output, and we can intervene at the level of the thought. So if I change the thought, if I catch it and change it first, which takes a lot of skill and practice, but is definitely doable, then I change everything downstream. So if somebody cuts me off in traffic, instead of thinking, what a jerk, if I think, oh goodness, I hope they're okay, I hope they're not having an emergency, then that's going to have a very different emotional response connected to it, probably concern, worry, which is not going to trigger the same physiological sensations, and it's not going to trigger the same behaviors. I'm probably actually going to take my foot off the gas pedal and give the person space, right? So these are all very connected, and so when we're doing CBT, we're teaching patients this triad, and we're helping them to learn a set of skills to intervene at changing your thinking, to be more helpful and more accurate, and also changing your behaviors, because if we change the behavior, we also can change the thought at the other end. So that's CBT. Most sessions that we use in CBT are highly structured because we're wanting people to understand these linear relationships, and the clinicians are very active. So we're really more of a teacher or a coach than we are in sort of a more passive supportive stance. So we're really encouraging people to learn a skill. The end goal of any solid CBT work is to have the patient be able to do it without you, is to teach them the skill set so that they don't need you anymore to be able to understand these cycles that are happening in their life. A typical CBT session is 60 minutes, and it's divided into 20-minute sub-sessions, and I'll walk through exactly what that means. We're always trying to teach and coach, so we're not being overly passive, and we're not being overly rigid. So we're sort of this coach interaction where we're like, tell me what it is you need, and let me tell you some skills that can help you get there. So the 20-20-20 rule in CBT is really important, and this helps us structure the work that we do with the patient in any given CBT session. The first 20 minutes, what we're going to be doing is setting an agenda, and that's the beginning of every CBT. We always have a clear agenda. Today we're going to be talking about X, Y, and Z. We never start a session with, how was your week? Because then that will eat up the majority of the time. So we always start, today we're going to talk about X, Y, and Z. You briefly focus on understanding how the X, Y, and Z you're going to talk about in that session relates to specific current concerns. So CBT is not really that focused on the past. It's much more interested in what's going on in the person's day-to-day life right now that we can make some changes with. You want to obtain detailed information as it relates to the skill you're gonna teach that day, and then you spend a little bit of time exploring their experience with any homework that might have occurred in the previous week. So another major component of CBT is all the work that patients do in between seeing you as the provider. So you always want to make sure that you check in on that. How did it go? Any additional supports that they need to continue to do their homework. The middle 20 minutes is where you introduce the actual skills. That's where you introduce whatever new technique you're going to focus on for that day. You, again, tie it into specific concerns the patient has. Make sure that it's very speaking at their level, that it's relatable to what they're doing. You're not using a lot of jargon, a lot of heavy concepts. And then you leave space in that 20 minutes to actually practice the skill. So it's not just teaching, it's saying, now let's apply it. Let's do this worksheet together, or let's practice identifying your triggers together, and you fill it out, you do the role play, whatever it is. So that way they have actual experience of it, and you're not sending them home to do something that they've never done. The final 20 minutes is where we check for understanding. So this is where we explore, did they really grasp what we were talking about? Do they understand the rationale and the utility of this skill? Do they understand how to practice it? So what the homework is going to be. And then you plan any high-risk situations that are coming up. Any solid CBT is going to ask them to look ahead for the week and say what's coming up that could be potentially problematic. What could get in the way of being able to do the practice? What could get in the way of potentially triggering some more use behavior or just deviating from whatever their goals are? So you're looking for problems coming down the road and spending a little bit of time problem solving with them. And then you can plan accordingly how they're going to handle that in the break between seeing you next time. Challenges that come up with doing CBT, even though this seems very straightforward and skills focused, is it actually can be quite difficult to keep patients focused, to keep ourselves focused. It's really easy to get distracted and pulled away from sort of that coaching, teaching role and go into, you know, the difficulties that patients have. The benefit of staying on point, even though we don't do it in a machine-like way, but we want to always be remembering it's not going to help them to spend a whole lot of time commiserating or talking about the problems they have no solution to. What is going to help them is teaching them a solid skill set that they can then apply to change some of those difficulties in their life. So always remembering that the ends is where you're trying to go. You want them to learn the skills to benefit their life and reminding them of that. It's really not going to help us that much to get too far off track talking about, you know, this difficult thing that we've talked about many times before. It's also easy for clinicians to kind of get a little complacent with the not doing homework, and it's really, really important that we set up from the beginning. Any of these skills that we're going to go over together have to be practiced outside of session or they're no good, right? So if I prescribe you a medication and you don't take it, it really doesn't serve its intended purpose. Well, these behavioral techniques work the same way. If they don't go home and take it, then it's not going to serve its purpose. So we have to always be reminding them and providing the rationale that practice is so important to this intervention. And then we just want to not fall into old patterns of treatment, whatever the relationship was before we started adding some CBT into the work that we're doing. General things to keep in mind, repetition is huge. So we know that what we're trying to do with individuals who have a substance use disorder are break some deeply ingrained habits. And so we have to have them practice doing different habits to replace those. It's very, very unlikely that somebody is going to change in a vacuum. Just having somebody stop doing something is almost never sufficient. They have to stop doing the maladaptive behavior and start doing a new adaptive behavior to replace it. So there always has to be a substitution behavior. So that's replacing habits and that's learning new approaches. And so that's why it's really important. We're repeating it, we're practicing it in session, we're having them repeat it outside of session. We also know that people who abuse substances typically have a lot of other complexities, traumatic brain injury, post-traumatic stress disorder, mood disorders, educational issues, all kinds of things that can affect their cognitive abilities and affect their memory. And so repetition is really important. We might think, you know, they've heard me say this 10 times, but they probably only really remember you saying it once or twice. And most of us need it repeated at least 7 times before it sticks. And so if you're working with someone who already has some impairment with their executive functioning or their memory, they're going to need way more than 7 times of the content repeated. So don't be afraid to just repeat. Whatever the skill is, practice it again. So a lot of those basic concepts can be repeated over and over in just different ways. You might repeat a whole session or parts of a session, just varying depending on what the patient needs. The other big piece that's very congruent with CBT is always providing a clear rationale. I think that it's really unfortunate when we ask a patient to do something and they don't really know why. They want to be good patients, they want to do what we're asking, but it isn't connected to their life in a way that they perceive it as being helpful. So that's why anytime you provide a new skill, or even if you're repeating a skill with them, you should constantly be stressing the importance of how this is going to be helpful to them, or exploring with them how it's going to be helpful to them. If they don't understand the rationale, they're not going to be bought in and they're not going to do it. Another important component is making sure that we monitor. We teach them how to monitor. So there in CBT protocols, there's a lot of logging and basically having patients track their use or their different behaviors, their triggers, the high-risk situations that get repeated. We teach them how to monitor, and then we remonitor. We do symptom monitoring at every encounter. So that way that we're keeping track on change or lack of change. And that allows us to make shifts in the treatment that we're providing. It also allows us to do this other important piece, which is praise approximation. So if we're not monitoring and we're not paying attention for those slight improvements, then we're not going to be able to reinforce them when they happen. And because these are new behaviors, they need to be reinforced whenever possible. So highlighting any positive change, including coming to the appointment. Maybe in the past they've come periodically or they haven't come consistently, they've missed a lot of appointments. Well, if they've shown to that appointment, that is something that can be praised. That is something that we can say, this was really awesome that you were able to do this. That slowly shapes behavior over time. So make sure that we don't miss an opportunity to praise them for any positive change, no matter what it is. And then talking to them about obstacles to practice, because 90% of doing cognitive behavior therapy is giving patients the tools to practice outside of session. If they're avoiding that homework and they're not doing that practice, they're only getting about 10% of the benefit from the treatment. So if they're not practicing it outside, that's a failure on us. We either haven't provided the rationale, we haven't reinforced it appropriately, we've made it too difficult. Something has happened where they're feeling hopeless and they're not able to prioritize practicing those new fairly difficult behaviors. So we want to look at that and really focus on that. That's why that 20-20 rule is so important. The first 20 minutes, you're talking about what you did last week. The last 20 minutes, you're talking about what you're going to do this week. So 2/3 of the treatment is just framing and helping people understand the importance of practicing those new behaviors outside of their time with you. So these are just some examples of how you can talk about overcoming obstacles. So you're going to have people come in and say, you know, I couldn't do it. I was too busy. I had my kids. There just wasn't enough time. Well, think about how you can frame that, because you don't want to get into an argument, but you want to help them to see, well, actually, if you can start by doing 1 or 2 things a day, that might make it easier. Or I understand it can be really difficult. Help me understand what could help you complete this, right? So it's sort of like, this isn't an option. This is part of what we're doing, but let's work together to figure out how to make this easier. Okay, so my last 10 minutes, that was my overview, basic overview of CBT and CBT skills. Now I'm going to show you some specific techniques that fall under the CBT umbrella within the relapse prevention category. So again, with patients that we're looking to help them solidly decrease their use and then maintain that decrease over time, this is when relapse prevention skills are going to be most beneficial. So one of the very first things that we do with patients, and that's core, is helping them to understand those environmental triggers. So just like the car cutting us off in traffic, patients have hundreds of thousands of things that occur every single day that are linked to their urges and cravings to use. So they need to understand those external and internal triggers to be able to change their thoughts about the triggers and manage their behavior around using. So if you think about it, there's always a thought before there's a craving, and there's always a craving before there's an urge to use. What triggers the thought? Well, those are unique to the individual. Those are the environmental cues that could be external or internal that are causing that craving to come into awareness. So one of the best ways to understand this is through classical conditioning. And many of you are probably very familiar with Pavlov's dog experiment. So this is where he was able to show that that brains, just like ours, link things in the environment to unconditioned stimulus. So just like with dogs, food causes salivation, right? When we smell pizza, we salivate. When dogs smell food, they salivate. So this is an unconditioned response that occurs to the unconditioned stimulus. Well, he linked something that wasn't conditioned. So he used a whistle or a bell and linked it with the food over time, and eventually the whistle or the bell was able to cue the same salivation response. So this is happening with drugs, and it happens at the very beginning and throughout all of drug use. This classical conditioning is occurring. So there are thousands of environmental stimuli that prior to the drug use were completely neutral. So that would have been like a gas station, that would have been a certain street, that would have been things like aluminum foil or cotton, or things that would have been completely neutral in the beginning. Because they've been paired with the drug use and the effects that the drug has on the brain, which is that unconditioned response, and it's been paired over time repeatedly, now they are themselves their own trigger, their own cue. So they become a conditioned stimulus. So just seeing a ball of aluminum foil is going to trigger the same compensatory reaction that seeing the heroin on the table is going to trigger. And so we really need to help people understand that connection and think through that connection, not just so that they can avoid the triggers that are avoidable, but also so that they can manage their response, knowing that it's predictable, knowing that it's going to happen. So how we can begin to do this is trigger identification using something called a functional analysis of drug set and setting. So it could look like this, which means just it's a worksheet that you guys can get after this lecture that'll have these questions on it that asks them to think through, okay, the last time that you used, who were you with? Where were you? When was it? What were the things you were thinking about? What were you feeling physically? What were you feeling emotionally? What were the behaviors connected to it? And then what are the short-term and the long-term consequences? This worksheet is going to give you a ton of detail about the individual's triggers. Or you can just ask these categories if you don't want to use something as structured as a worksheet. But once you have those triggers, then you can actually begin to do something very clear with it. So, and that means helping them to understand the behavioral contingencies that get linked. So understand that people respond to consequences. We respond to rewards much better than we respond to punishment, but we will respond to both. And that's one of the reasons why drug addiction is so difficult, is because oftentimes the reward outweighs the punishment, and eventually the reward just becomes not getting sick, right? And that outweighs any potential punishment. So the effects become more pronounced when they're rewards. So we need to match that as treatment providers, which is why it's so difficult to ask people to stop in the absence of something else. It's why they need to replace that behavior with something and be reinforced. So how does that apply? Well, the first thing we need to do is identify some behavioral targets that we want to reinforce as providers, or that they can reinforce. So doing things like reinforcing attendance or lack of use while they're in treatment. And thinking about what are the externally motivating things that we can link it to. Because if we're just expecting that internal motivation to be there, it's probably not going to be very long-lasting or effective, at least at the beginning. So behavioral contingencies for most folks like us are things like going to work and getting a paycheck and being able to pay for our mortgage. Well, for a lot of the patients that we work with, they are so far removed from being able to have the internal motivations for that kind of reinforcers, that they need something very present and immediate to replace the substance use with. So something like a gift card program, or sobriety chips, or even public acknowledgement, like applauding them in front of other people. So helping them look through something like this, an alternatives to use table, is going to identify what some of those contingencies might be for them. What are the things that would actually be reinforcing for them, unique to them, that they could do instead? So what is that replacement behavior going to be? So having them look at the triggering situation and what they would get out of using, because obviously they're getting something out of it. And then what would be an alternative activity, and what would be the positive outcome of that, right? And have them sort of weigh the pros and cons of doing one versus the other. And then lastly, identifying triggers leads to being able to use this core skill, which is urge management. So understanding, okay, I know what my trigger is. I know what's going to happen when I get triggered is I'm going to have a really strong craving or urge to use. What do I do with that when that's there? So that is where we can teach patients a lot of skills like recording their urges to use so they know the intensity. So sometimes the intensity will vary and they might have to match dealing with that urge with a higher intensity intervention than a lower intensity. So they first need to be able to self-monitor and say, this is the triggering situation, this is the urge to use, and it's at this number of intensity. And now here's a list of different ways that I can handle it when it shows up. Here's another self-monitoring log that you can look at. But one of the best ways that we want people to think about managing their urges is something called urge surfing, which is just teaching them that this is temporary. Even if you sat there and did nothing for 30 to 45 minutes, it will go away on its own. It might come back, just like waves in the ocean, it might come back, but it will recede. It will go away if you do nothing. The problem is every time you act on that urge and you go and use, you've now reinforced it. So it's sort of like you fed the fire. You've made it more intense and harder to overcome versus if you just ignore it and you do nothing, you do not respond, it will quiet down. That fire will burn out and it will pass and it won't come back as strong as it did the first time. Most urges typically peak within 20 to 30 minutes. So we give people a list of distraction techniques that they can use for that 20 to 30 minute period while they're waiting for that urge to pass. The other thing is they can practice some cognitive techniques to actually manage that urge. So thinking about labeling it differently and actually moving through it, like thinking, instead of filling the syringe full of heroin, I'm filling the syringe full of bleach, right? So imagining it being something really caustic and terrible that they don't want to put in the body. There's a whole list of different techniques that patients can use to manage the urge. But the most effective thing is teaching them the structure in which they can approach it. And then lastly, part of urge management is this thing that it will be basic to every CBT session, which is that last 20 minutes, you always identify the high-risk situations that are coming up. So just like we have fire drills, we need to know where the exits are. Patients need to know how to manage a really high-risk situation. So that's a situation that they are likely to use in so that they can begin to avoid those situations and move towards low-risk situations as part of their daily life. So differentiating between this set of situations, I'm definitely going to be triggered to use, and those urges are going to be so intense, it's really going to be difficult to ignore it or wait it out, versus these lower risk situations, which are going to be much easier for me to manage. And I have a set of tools that I can begin to practice in these lower situations. So being able to differentiate between those two types is the first step, decreasing their amount in high risk and increasing the amount of time in low risk. And then using a worksheet like this every single week. So coming in and saying, okay, what's going to happen over the next week? Well, I'm going to go to a birthday party at my cousin's, and I know that the guy I used to score from is going to be there, and they're going to go use out in the garage, and they're going to invite me to come because they're used to me coming out. So okay, that's the situation. Let's come up with 3 different alternative ways that you can handle it. Number 1 being don't go to the party. Number 2 being you go to the party, but you bring a friend from NA with you, or you bring your grandmother who needs you by her side the whole time. So you're not going to want to go off, and you're going to have a really convenient excuse. You can brainstorm with them how they can handle that situation, and then you encourage them to keep this worksheet on them, like in their wallet or their purse, so that they have it whenever that situation presents. And then they can work through it. And then when they come back, you check in and say, okay, which one did you use, A, B, or C? But they always need to have a plan. Typically, they need to have a daily to weekly plan, not longer than that, unless they've been doing this a really long time and they're very practiced at it. But this is one of the most important, most beneficial CBT tools that we can give people for managing triggers is this high-risk situation planning. Okay, does anybody have any questions before we move on?